Okay. Good morning, everyone. Welcome to this session about the health sector and strengthening civil registration and vital statistics systems. We have a very interesting panel this morning, at the moment consisting of 3 panel members, which I will introduce to you in a minute. And we still hope our 4th member will join us, but it does mean we have ample time for discussion on this important intersection between health and CRVS. So on my right I have the Honorable Minister Ramela, who is Minister of State for Health from the Maldives, Mr. Lovias Nakiri, who is Director of Department of Planning and Health Information in the Ministry of Health in Cambodia, and Mr. Peter Harper, who is the Deputy Statistician from Australia of the Australian Bureau of Statistics. Just a few words of introduction from my side. Of course, in the health sector civil registration, vital statistics systems intersection is very important. In health, we need good civil registration, vital statistics systems to be able to plan and more effectively target health services and interventions. We also need a strong CRVS to have reliable vital statistics for small areas that are continuous over time, so mortality by age, sex, and cause of death. The health sector can also be a very significant contributor to strengthening CRVS. Notification of births that occur in health facilities, regular certification, recording of death and causes of death, and innovative approaches around reporting of birth and death, causes of death, and we'll hear more about that in this session. I think over the last 3-4 years, there's really been a lot of momentum in the health sector to try to strengthen civil registration vital statistics systems. And it sort of all started with the report of the Commission on Information and Accountability for Women and Children's Health, which included 10 recommendations, and the first one was about strengthening civil registration and vital statistics systems. That led to some significant resources for this from Canada, Norway, and UK, and helped many countries conduct a systematic assessment of where their system is at the moment, and also link that to further development of a plan. It also helped WHO and others in the health sector work much more closely with the regional commissions, such as ESCAP, but also ECA and ESCAP, and global partners to mobilize much stronger around the issue of CRVS strengthening, which had been quite low on the agenda for many, many years. At the same time, the health sector is not an easy sector. It's quite impatient. It wants to see results, and it wants to see results for investments quick. It wants to innovate. And I think that is a challenge in CRVS strengthening, because there is a tendency to do things separately or without strengthening the system. So outside there's a publication which is a summary of a meeting that we held in December 2013, which came up with 4 core principles of how the health sector should engage in activities related to CRVS strengthening, but in a way that it would strengthen country systems. So the first principle is really that the health sector and CRVS interactions should be based on principles of mutuality and partnership, and be supportive of country ownership and leadership. So health platforms and innovations should be leveraged in ways that they strengthen and contribute to system-wide development of CRVS. Now, within that sort of overall principle, there were 3 specific action areas. One is around innovations in tracking maternal, newborn, and child health, of which many are being introduced in many countries now, should contribute to strengthening modernizing CRVS. So this means closely linked to notification, registration, and certification of the relevant vital events. The second one is around the death and causes of death. So deaths are reported in a complete and timely manner, including accurate recording of causes of death. So all deaths that occur in health facilities should be medically certified by a trained physician using the international form of the cause of the death certificate, and include the underlying cause of death and then notify to the registration authorities. And then the fourth part is that health sector activities should contribute to improved vital statistics for policy, planning, and programming. So not invest greatly in separate activities, but do it in a way that strengthens civil registration and vital statistic systems. And we'll come back to that towards the end. So these are four very important principles for the health sector to try to work better toward and contribute towards strengthening CRVS. But let's now move to our panel and hear from first two voices from the health sector on what is going on in their countries and what is their perspective on this intersection, health and CRVS, and then to colleagues who have a broader view more from the statistical side or planning side. So, Your Excellency, Minister Ramela of the Maldives, you have the floor. Thank you.
Thank you, Chair. And good morning, delegates. As the first speaker of today's panel, I've been just given the task to elaborate on what's happening in my country, the Maldives. As of now, we are having a very high registration rate, both in the birth registration as well as death registration. Both is above 90% at the moment. And we also have a very high percentage rate of other vital statistics registration, that is the divorces and the marriages. When looking at the things that needs to come in order to improve CVRS, I think even in Maldives, we have an issue with the coding of death. Though we have very high percentage of death registration, the coding still needs to be improved. For all of you who actually know the geographical situation of Maldives, we are very widely scattered, and we have like 200 islands in the country, and some islands have a population of about 300, very small communities. Even with the wide scattered geographical situation, we still have a very high percentage of reporting, which is very good, but our policies states that all deaths has to be certified before the burial takes place. That's the reason why registration is very high, because all the deaths will be certified before the deceased can be buried. But again, the person who certifies the death may not code it appropriately. We are using the ICD-10 for coding of death, but as we have a very high turnout of medical officers, we have foreign doctors who work with us, who comes for a brief period of time and who leaves, making it a very high turnout. And if we don't have good orientation packages provided to the doctors, at times the doctors lack information on the coding system. And it's very common to code the death as unknown causes. For example, they might even say it's a cardiac arrest of unknown cause, or unknown cause due to fever, something like that. The real coding is not done. But though from the Ministry of Health we are making aware, or we are sensitizing the doctors who come in on the system, I don't think it's catered adequately. And we are finding that there is a lack in coding. How we have the very high percentage is that the people who bury the dead bodies, they are strictly, they have to follow the policy that they have to have the certified document with them. The document has to come to them before they can bury the dead body. But again, there should, in Maldives, we too find that the linkage between the other partners in CRVS has to be strengthened. All our births takes place in a hospital situation. And every mother who gives birth is given a delivery form. It's actually called a delivery form, which specifies like the details of the mother and the baby, the type of birth, whether it's cesarean or spontaneous or forceps delivery and all these things. And this form has to be taken to the registration office within 7 days for birth certificate. So what the challenge here is that though the mother is given a birth, the delivery form, it lies on the parents that the birth certificate has to be obtained from the registration. But what we feel is that there should be a linkage between the hospitals and the registration office so that they know that a birth has taken place. Because this delivery form does not serve as a birth certificate. The parents has to actually go to the registration office with a name to the baby and then get the birth registered. And though our policy says that it's 7 days, we do have cases where it prolongs beyond the 7 days. Not because there is inaccessibility, because in every island registration can be done. And in major, we have 2 cities right now, and in the cities we have different spots where registration can be done. It's just not one place that the registration is done. But for different purposes, there are delays beyond the 7 days. And a concern right now is that we impose a penalty after 7 days. And when we look at the kind of parents or the cases where there is delay, we find that it's very vulnerable parents that actually gets delayed registration. Maybe single mothers, maybe mothers of very poor economic status. So when we again impose a penalty, it again makes it difficult for the parents to get the child registered. So that is one thing that has to be actually, policy consideration has to be given, and a way out should be found. Otherwise, penalties, we've recently found a child who is 7 years old who had no registration, and the penalty is going beyond 10,000 Maldivian currency. Again, mother is very poor, single mother who cannot actually pay for it. So these kind of things actually makes it a bit difficult when they go beyond the stated duration of registration. Similarly, all the deaths are registered then and there. As soon as the document is given, it has to be taken to the councils for cancellation of the person from the register. We have a register to each household. So the person's name will be cancelled from the register and it will be shown as a death. And the other thing that I would really like to highlight, or maybe I can keep it for the next question. A second round of questions, maybe we can hear from other countries, like how their status is. So as far as Maldives is concerned, our rates are quite high, which is very good, but still we have to look into the fine details of how we do it, and needs to improve on it so that we can raise our percentile to even a higher percentage of registration. Thank you, sir.
Thank you very much. Maldives, we use a sort of 3-group classification of countries in terms of what interventions would be needed to strengthen CRVS from the health perspective. And one is sort of registration levels are below 60%. The second group is between 60 and 80%, and then the third is over 80%. And as we heard from the minister, coverage is over 90% of both birth and death registration, which puts you in the high-level category. And it's really about improving the quality of, in this particular case, the causes of death, which is a big challenge. And maybe just one question before I move on. Have you tried any innovative approaches to improve, because high turnover rate of doctors is quite difficult to change, but in terms of making the capacity of doctors to properly certify, properly fill out a cause of death form, and also to code or find other ways of coding so that it doesn't depend on the doctor. Have you sort of given consideration to those?
Yes, thank you. We do have coders sitting in the Ministry of Health also, whereby the forms that comes, which can be actually coded by our coders, like one of my assistants is here who does the coding. So we do also do coding at the ministry level as well, and because all the forms will come to the ministry also, a copy of the form will be coming to the ministry. We give the original to the family, and the copy will always be retained in the hospitals, which will ultimately come to the health ministry. And all the data will come to the health ministry, and we do sometimes do coding, but again, I think we still require more sensitization and more information has to be spread out to the island level, where maybe manuals or booklets can stay with the health center or the hospital for the doctor's references, or where a doctor is not there, the person who, the health worker who certifies, like, to go through. So those kind of things has to be done. And currently, if I'm not mistaken, we do have manuals and handbooks already given to the doctors. But again, I think it's a time of, it's a matter of interest on the person's part who actually declares the death, to give adequate consideration to coding, because ICD coding, it's very vast. Like for one simple cause may have different sub causes also. So it needs a lot of interest and a lot of going through the customizing to the codes in order to give a correct specified code.
Thank you for that clarification. I mean, there are several things that are being tried to improve this process. One, there is actually, WHO does have a web-based self-training package for physicians and others to fill out the certificate. I don't think it's good enough, but it would help, say, remote doctors who have access to the web to find out how to fill out the certification. Yes?
We have already, we are having it, and we are in the process of actually having the web-based one on the coding. It's already with us, the system is in place, and it's probably this year we'll be implementing it in all the islands.
Right. I mean, some countries use electronic, use software to do the coding. So the certificate is read, and then it's coded using Iris, a piece of software that some of you may know. And thirdly, it is complicated. The ICD has many, many codes, and we also have recently developed a shortlist, which is just over 100 courses, which could be used in settings where the full list is impractical. So thank you very much. That was a very interesting perspective on the causes of death. So I now would like to move on to Dr. Kiri, who is the Director of Department of Planning and Health Information in the Ministry of Health of Cambodia.
Okay, good morning, Excellency, ladies and gentlemen. I would like to highlight 3 case interventions which currently is implemented in the sector, and I hope that this will contribute to the improvement of the civilization. The first one is the application of the web-based health information systems, which currently operated nationwide. This system also includes the vital events, including birth deaths, and also the cause of death. So the system has been covered the modern Southern Health Center and the 92 referral hospitals. They have to report to the system on a monthly basis. However, there is still the room for improvement of the cost of that at the facilities levels. So recently, MOH has initiated to work on the introduction of the ICD-10 and incorporate this into the health management information systems. The second intervention is the introduction of the marginal death surveillance system, which is one of the core components of the government roadmap for accelerating the marginal mortalities, marginal and the newborn mortalities. So the marginal death surveillance systems has been introduced in 2010. So the system has to provide the real-time information about the suspected marginal deaths, either both occur at the public health facility or outside the public facility, for example, in the private sectors. So this system also has been upgraded to be the web-based systems. So the public health facility across the country had to report on a weekly basis to the Ministries of Health. And then we can look at the data, how many suspected marginal deaths occurred during the weeks. The information from the marginal death surveillance system will be informed the marginal death audit process. Because Cambodia has established the national committee for the marginal death audit since 2004. So as soon as the marginal death surveillance system notified to the marginal death audit committee, which exists at each level of the health system, from the national to the subnational levels. So the technical team, the professional technical team at the district or provincial level, they had to conduct the marginal death audits by using the marginal death audit guidelines adopted from the WHO guidelines. And the third intervention is the introduction of the patient medical record system, which recently, over the last 3 years. So the system has recorded the individual patient profile and also the notify the diagnosis of the discharge by using the ICD-10. So the ICD-10 now is just initiated. So MOH is planned to use the ICD-10 to specify the code for that and then incorporate into our routine health management information systems. And the other challenges, if we look at the data reported, basically through the public health facility. The data is very, the completeness of the reports almost 100%. And the data quality is very good. We had did 3 rounds of the data quality assessment by using the WHO data quality standard. And the assessment found that the completeness of the reportings, the quality of the data, including the consistency of the data, is quite high. But this only the data that we collected through the public health facility. So I think the challenge is to engage or to encourage the full participation of the private health provider to report through our system in order to get the full pictures of the vital event, in particular for birth and death that occurred at the private facility as well as at the communities.
Thank you very much, Dr. Kiri. So you really gave us 3 examples of innovations in the health sector that have a link with CRVS. The first one was a web-based health facility reporting system from mostly the district level, which, as you said, was really of good quality, and we've looked at it, and it's really very high, complete, and very timely. The second one is the maternal death surveillance and response, or audits. And maternal mortality is a big concern. It's an MDG. It's very likely to continue to be very important in the post-2015 development agenda. The measurement of maternal mortality is really difficult. So counting every maternal death would be a solution. And there are significant investments. And for instance, the Cambodia example is important because I think you've tried different ways to get as complete reporting as possible. The third one is the patient medical record system. So now we're really going to individual electronic information, and that of course is a big step. Many countries are making these steps. It's going to create a lot more data, and also on vital events this could be important. Now, in spite of the private sector issues, which of course all countries face in one way or another, my question to you is really, now with all these innovations, how do you in the health sector make sure that the overall strengthening of the civil registration and vital statistics system in Cambodia is linked and benefits from these investments?
From the statistical viewpoint, the MOH, in our Health Information Strategic Plan, we also include the several interventions. We maybe support the improvement of the CVOS. Because strengthening the CVOS, we need the support from the different sectors, in particularly for health, and also from the other ministries, like the ministries of planning. So I think interventions that we implemented or the carried out in the sector, it should be put in our plan for interventions. And the cross-cutting, because there would be some cross-cutting interventions, which need the joint effort and the joint funding to support that interventions.
Thank you very much. So let's move on to our third panel member, Mr. Naeem Uzaffar, who is a member of the Planning Commission in Pakistan.
Thank you. So before talking about modernizing the role of health sector in improving CRVS in Pakistan, I'll sketch a brief of Pakistan so that it may give you some idea about the demographics. So Pakistan comprises of 4 provinces. Its population is 180 plus million. Punjab is the most populous province of Pakistan, and it has population of 100 plus million. The last census we had was 1998. We are planning one, but still that's the information which we use to construct a statistical model to have some idea about the demography. So roughly 55 to 60% of the population lives in rural area, whereas 40 to 45% lives in the urban area. And then we have a system of primary, secondary, and tertiary healthcare units, which is providing healthcare to rural population and urban population. The births in the villages are usually done by trained midwives and lady health workers who are by and large certified, and the births in the urban areas are done in the hospitals. So the births which are done in the urban areas, there is a registration system, and the parents get a provisional certificate which they have to take to the registration authority located in the community within a month to get the birth certificate. This trend is quite strong in urban areas, but in rural areas this practice is not followed. So we have an issue of big size of population and big number of births which are not registered. Punjab, which is the biggest province of Pakistan, and its population is a little more than half of the overall population of Pakistan. They took initiative a couple of years back, and they related the mandatory presence of the birth certificate in order to qualify for the free basic education. Not mandatory, they kind of encouraged parents so that if you want to have the free education, it's better that you produce the birth certificate. But in urban areas, they were able to enforce on it and improve their birth registration substantially. But again, in rural area, that policy did not meet with success, so they kind of abandoned it. Instead of coercing, they started thinking of other measures. For death registration, there is substantial trend in urban area because of the inheritance, but again in the rural area, deaths are not certified. Then I come to the medical colleges, which can become a source for ICD. Again, we have a mix of colleges, some colleges which are by and large teaching the same syllabus, which was not using ICD training in their epidemiology or community health courses. And then we have a couple of medical colleges which are more modern, and they are training the doctor, but those doctors are usually, they don't get employment in Pakistan and prefer to go overseas. Currently, we have made a steering committee which is comprising of, which is under the, which is headed by Planning Commission, and it is comprising of NADRA, the biggest network of civil registration we have in Pakistan, and the provincial health ministries and representative from provincial planning department. And we have identified 6 major areas related to the legislation, related to the ICD, related to the cross-cutting issues. We are trying to devise a system which we can build and install at the community level to install CRVS in our country, but that's it in the budding state. We are working on that.
Thank you. So, as you explained, of course, it's a huge challenge in Pakistan. Enormous population, 60% rural. And it's very interesting you mentioned the steering committee at the end. So the Planning Commission is heading it, and because of the way you organize, you have provincial health ministries and then planning departments, and have prioritized, you said, 6 issues, legislation, ICD, causes of death, and some of the... So, I mean, given that the health sector, it tries to innovate in some areas, I would say around maternal and newborn and child health, it may not be everywhere, but they're trying to do that. Are they really doing the things that they need to do to sort of catalyze the CRVS strengthening? Because, I mean, that is not an easy task, and it not always... There's a short timeline in the health sector often, and there's a longer vision in the CRVS.
Yes, you're right. So currently we are focusing on somehow registering the birth. And we are thinking that how can we relate the hospital data with the NADRA data. NADRA is the biggest registration authority working under the government, and it is it's state-of-the-art equipment, but the problem is that it's not very much accepted by the society because of conservative or because of that people are scared of new things. So diffusion of this phenomena is an issue, especially in the rural areas. So we are trying to work out a model in which as soon as there is a birth in hospital, the data may be communicated to NADRA instantaneously via technology. And then, so the data is there and the event has been recorded. Now it's up to the parents. If they want to take a certificate, they will have to pay a minimal fee. And again, we are thinking of measures that if this can be done in a mean-tested way, if they can substantiate that they do not have resources, even that fee will be waived. And that will, I think, provide a booster for parents to get the certificate. So we hope that in coming couple of years, we'll make use of technology to increase the birth registration.
So that's within health facilities. How about the lady health workers and trying to get also out to the rural areas and the communities?
Yeah, alongside we are making a program of little goodie bags, which is some basic healthcare kits, some hygiene teaching material, some very cheap soaps, and we plan to give it to lady health workers and send them to the rural areas. So if they are attending delivery, they will give that kit to parents and encourage them to register. So we hope that that way we will incentivize the rural folks also.
Good. Thank you very much. I'd now like to move on to our last speaker, Mr. Peter Harper, who is Deputy Australian Statistician with the Bureau of Statistics there.
Thank you, Chair. I'll start off by making a very obvious statement, but I think it is worth making because I think it's important that we always keep this in mind. And when we're talking about vital events in people's lives, The two most critical are obviously a person's birth and a person's death, and these things are essentially health events. They are the two most significant health events in a person's life. So a well-functioning civil registration vital statistical system has to start with that in mind, that these are effectively health issues that we are measuring, and then everything else flows from that. And because of that, in order to have a high-quality civil registration and vital statistical system, there has to be a strong relationship with the various health agencies and the registrars and the statisticians in order to produce good quality information and including high-quality statistics. And fortunately in Australia, we have a situation where there is a very close relationship between the health authorities and the other players in our CRVS system. Another observation I would make is that the information that comes out of the civil registration and vital statistics system, particularly the vital statistics bit, is of critical importance to health authorities for planning purposes. So not only do health authorities play an important role or a critical role at the start of the process, they also have a very significant role at the end of the process in terms of being able to utilise that information in order to deliver better health services and achieve better health outcomes for their citizens. And this is very useful, I think, because in order to encourage the health authorities to play the best role they can at the start of the process, it's useful to remind them of the importance of the information at the end of the process for their work, because that will encourage, I think, greater involvement and greater cooperation from the health authorities. They need to see themselves not just as people who provide information into the system, but people who see themselves as beneficiaries of the system. And again, in Australia, we're fortunate that our health authorities see things that way, so that they are willing to be strong players within our civil registration and vital statistics system. Australia, as some people may know, is a federation. We are comprised of 6 states and 2 territories. And in other countries, like other countries that have a federal system, responsibilities for health are distributed across governments in Australia, and likewise responsibilities for registration are distributed across governments in Australia. So in other words, each state and territory has its own health system, and each state and territory has its own civil registration system. One area where we are fortunate, though, is there is only one statistical system in Australia, and that is with the Australian Bureau of Statistics. And because we live in a federated environment in Australia, we have to develop a system that doesn't just embrace a national civil registration authority and a national health authority. We have to build a system that embraces 8 health systems in Australia, 8 registration systems in a national statistical system. And we have been able to do that. We have been able to build up an integrated, joined-up system across all of those various players. We've heard a number of times over the last few days of the importance of coordination in developing a civil registration and vital system, and I think the ability of Australia to be able to do that in very complex circumstances demonstrates that that is indeed possible. So, turning to some of the specifics of the Australian system and the role of the health sector, if we look firstly at births, then the registration process in Australia requires 2 pieces of information. It requires firstly the notification of a birth from a health agency or a health authority, and it also requires family information, which is provided by the parents of the child who has been born. And those 2 pieces of information validate each other, and they're both necessary for the registration process. So all births in Australia, and most of the births in Australia actually take place in a health facility, are automatically notified to the registrars, so that the registrars are then aware that they then subsequently will get some family information which will be needed to complete the registration process. And because most of the births in Australia do take place in hospitals, the hospitals not only provide the birth notifications, but they also facilitate the collection of information from the families in order to complete the registration process, and that is done automatically. When we turn to deaths, again, the process in Australia requires multiple players. It is the responsibility of funeral directors to notify the registrars of a death, but it is also the responsibility of the health sector to provide a medically certified cause of death. And again, both of those two processes are done on an automated basis. Both of them work together in tandem because a funeral director cannot bury anybody in Australia unless there is that medically certified cause of death. So again, we have the intersection of the medical information, which comes from doctors, along with the family and other information that we need that comes from the funeral directors. And because Australia is very formalised practices, 100% of deaths would go through those processes. There are some deaths in Australia, like in other countries, that are subject to further investigation through our coronial system. In those cases, there is an interim cause of death determined, and then subsequently that cause of death is finalised as a result of those coronial processes. And of course, the health sector plays a vital role in coronial processes as well as in the causes of death where there are no need for any coronial investigation. A feature of the Australian system is that while the medical profession provides information about the cause of death, the actual coding of the cause of death in Australia is done by the Australian Bureau of Statistics using automated software. We think it's important in Australia that the coding is done by professionally trained coders within a statistical environment based on the information that's provided by the doctors. Doctors should not need to be trained in coding. They need to be trained in producing good quality information about cause of death. But it is, we believe, a better use of resources to have the statisticians who are trained accordingly in order to provide information about cause of death. Just one digression there in terms of our death statistics. We produce death statistics within 12 months of the end of a period. The cause of death for all deaths is not finalised within that period of time because there can be some open coronial investigations. So those statistics that we produce are preliminary, and they will subsequently be revised as those deaths that are subject to coronial processes become finalised. And I know that in some countries there is a debate about whether you should wait until you have all coronial cases finalised before you provide cause of death or death statistics. The problem with that, of course, is that it may take several years, and in the meantime, policymakers, including those in the health sector, do not have the necessary information available. So, as I said, Australia's approach is to provide preliminary information and then revise it as subsequent information becomes available. Another important innovation in terms of Australia's civil registration of vital statistics and its intersection with the health sector is that we produce microdata, which is basically a file of all births and also a file of all deaths in Australia. Identifying information is stripped off, but the other information about, for example, the cause of death and family characteristics is retained on that file. And that file is made available to medical researchers, to health agencies, and to others who are interested in analysing mortality. And that provides a very useful tool in terms of people being able to dig down into the data and find out things that might not be evident in the high-level statistics that are produced by the Australian Bureau of Statistics as a matter of course. Australia is also very keen to work with its neighbours in the Pacific in terms of improving their vital statistics and their interaction with the health sector, particularly around cause of death coding, and ensuring that appropriate capability is developed in that particular area. So, in summary, the key features of the Australian system is that it involves multiple data sources that come from a range of players, of which the health sector is a critically important part of that. It involves the sharing of data. The system is highly automated, so that there is a rapid transfer of information from the health facilities through to the registrars, through to the Australian Bureau of Statistics. It's integrated, even though we have to herd cats right across 6 states and 2 territories. We are able to do that in a way that is joined up. There is a clear understanding of roles and responsibilities. And most importantly, the players in the system in Australia, from the health sector through to the registers, through to the Australian Bureau of Statistics, see themselves as partners in an initiative which is vitally important to Australia in terms of the information that it provides for effective decision making in our country. Thank you.
Thank you, Peter. I think this is a nice overview of the role of the health sector as provider of information to the civil registration vital statistics systems, and as user, particularly mortality by age, sex, and cause of death. And in fact, I mean, this of course is the big gap in information that over 100 countries are facing still. Just, I mean, you mentioned some of the challenges of a federated system, but you managed to produce vital statistics. You now have microdata available, which of course is a big step forward and very important for understanding what people die of, where they died, inequalities, and so on, that then the public health system can address. What kind of structure or capacity do you have within the Australian Bureau of Statistics to produce those vital statistics?
We're very well resourced, fortunately, in the Australian Bureau of Statistics to produce vital statistics. And there's 2 reasons for that. Firstly, because we do live in a federated system, vital statistics are critically important in determining the population estimates of Australia. We use a simple model that you start off with the population at one period of time, you add in those that were born, you take away those who have died, you add in those who migrate to Australia, and that gives you your population at the end of the period. And then that information, when it's classified by state and territory, is used by our federal government to allocate funds. And because billions and billions of dollars are dependent upon high-quality population estimates, we are well resourced in terms of producing those basic population estimates. But when it comes to the detail, things around causes of death and other more detailed aspects of our vital statistics system, there's the recognition of the strong role that information plays in delivering an efficient and effective health system in Australia. The amount of money that the Australian government spends on producing detailed vital statistics around things like cause of death is very, very small compared to the total budget in Australia for health issues. And good quality information can be worth billions and billions of dollars in terms of high quality decisions that are taken within the health sector. So in recognition of that, the Australian government provides us with good resources in order to produce that information, because it sees it like an investment in information to underpin effective public policy, rather than necessarily a cost that you incur and you get no long-term benefit for. We also maintain very close relationships with our federal Department of Health as well as our state government Department of Health, and they become very effective advocates for us in ensuring that we have the right resources and develop the right capability within the Australian Bureau of Statistics to produce those statistics. Thank you.
So good quality statistics not only save lives, they also save money. Before I open up, I have one more question from my fellow panel member to Peter.
Peter, you, while you were describing the role of your statistical organization, you said that statisticians collect the death data. So I was just wondering, do they have any formal training in ICD, or what is their background?
Yes, you're right. We get the death data through the registration system. We code it according to ICD, and we do train our coders in ICD, and we do use automated software in order to facilitate both a more efficient and a higher quality coding service. We put a lot of importance in having high quality coders. It is a specialised occupation within the Australian Bureau of Statistics, and it's one that we make sure that we get good quality people who have the right sorts of attributes to do that work. It may appear as a particular cost within a statistical system, but as I said earlier, I think that is much more efficient than trying to get a lot of people who are not experts in coding, either doctors or other people within the health sector, to try and do this. And while those costs may be not as visible, I think if you added it all up, the cost would be a lot greater, and the outcome would probably not be as good quality. Thank you.
So we've heard a whole range of issues, challenges, like how finding ways to get people motivated to register, and how the health sector could help with that, to improving cause of death information in health facilities. We didn't talk much about how it can be done in communities with verbal autopsy, but that's of course another challenge, to even issues around individual records and how one could share those. And we've heard quite a few solutions, things that are going on in the health sector that we can leverage to, if they're well linked, to strengthen civil registration and vital statistics. So the floor is open for any questions, issues you want to raise to the panel. Malaysia.
Mr. Chair, thank you very much, and panelists. I think this is one of the brilliant presentation and very relevant to us when we talk about data quality. One of the things that we realize that we need to improve is on the tripartite arrangement between the Ministry of Health, who notify, and it goes to Department of National Registration Department, and finally the statistic is produced by the Department of Statistics. If the tripartite arrangement is not established now, we are afraid that in the near future there will be further miscommunication, and especially when we are dealing with data quality. And National Registration Department has agreed to write a cabinet paper to endorse the establishment of this tripartite arrangement. And that is number one. Number two, we have some issues with regards to data quality, and I was very happy to hear the experience from Australia, and it confirmed and concur with what we are trying to do about data quality. Number one is about doctors shouldn't do coding unless they are professional coders. There was an attempt by some group of people when we move into electronic system, they ask the doctors to code, and we get a massive error rate in the coding quality. So I thank you, the panel, for concurring the finding with us. We are now insisting that there are two levels as far as data quality. We train the doctors to document the diagnosis properly, including cause of death, and then the data, the coding is by the professional coders, and they will have to undergo training as well as certification before they can do the coding. Number two, we talk about microdata, and I'm glad Australia is also sharing with us what they are doing. We call it granular data, where you collect the info at that level. And then that could help presentation of our statistic. For example, when there is a change in the policy about what is low birth weight, what is preterm from 28 weeks to 22 weeks, if data is collected at the aggregated level, there's not much that we can do rectify or to reproduce the statistics. And we are also now moving towards that kind of data collection. And that's why I was very happy with the presentation with Australia, because with data collection of that nature, we can reproduce, reanalyze our finding to reflect the new definition or interpretation. So if the tripartite arrangement is fully established, then it can be conveyed and communicated properly. Yeah. So there was a discussion among us recently because National Registration Department collected low birth weight, I think, cause of fetal death at 28 weeks. And then they missed on the notification that it is now below 22 weeks. So there was this misinterpretation. And then there was also misinterpretation about, you know, when we document under cause of death, it includes cause of death and underlying cause of death. But because WHO used the term cause of death, what was transmitted was the cause of death, when WHO actually is interested with the underlying cause of death. So I'm seeking one of your colleagues, Mr. Chair, to discuss with us and harmonize our understanding, because it looks trivial, but it is big. Yeah?
Thank you very much.
Sorry, the third one, sorry. The third one is about medically certified. I was made to understand that medically certified is only by the doctors, but recently there was a move to include that medically certified of other categories of physician assistant and so on. So if you could clarify on that too. Yeah.
Thank you very much. Let's take a few, and before I give the panel a chance to answer. So, Bhutan?
Thank you, Chair and the moderator. Thank you all the distinguished panelists for giving your insightful experiences specific to your country. Well, my question is very straight with regard to the civil registration vital statistics coverage. We live in the glory of coverage of 90%, 80%, 70%. But when you tease down the coverage of CRVS, we always find the issue of completeness and reliability is lagging behind always in every country. So is there any gold standard or any good practices or the other innovative solution to being at par the coverage and the completeness and the reliability of the CRVS system? That's the one question. When it comes to the ICD-10 coding, I think there's lots of challenges. I mean, coding itself, if you go more in depth, more than 3 characters coding is kind of bizarre or without, adequate knowledge. I think there's a demand for more than the disease-specific coding, but more than the 3 characters coding seems bizarre. But through this panel, we are good to learn that there are simplified version of ICD-10. Now ICD-11 is also coming up. So we wish to have very simplified version, or adapting ICD-10 whole volumes into the country-specific is indeed a mammoth task again. So in this context, I would like to ask, Mr. Peter Harper, how does your automated kind of coding system works in your Australian Bureau of Statistics when you do the coding? If you could elaborate some experiences or good practice, we would be very thankful. Thank you, Chair.
Thank you, Bhutan. Iran.
Thank you, Mr. Chair, and thank you for your presentation and also good discussion. As you mentioned, we in the health sector, we need the information, especially information on causes of this. But maybe the most challenge for the civil registration data is the causes of this, especially for categorization and classification. You mentioned about the software that is available for automatic coding system, but there is a need, and we have to work internationally or nationally to expand the automatic coding. For example, you mentioned about the iris, but when we want to use the iris at the national level, we have problem because it should be customized according to the language and according to the system. I think it is better we have an assistant from the international organization, especially WHO, to assist technically the countries to customize this automatic software to use for the country. So we can have an automatic system for coding system for causes of this. And this helps to improve the quality of the data because, as you mentioned, the coding system need more manpower and taxful people to code the system. And recently, and in the future, we wanted to change the ICD to ICD from ICD 10 to ICD 11. So if we wanted to have a good quality data on causes, information on causes of this, if we have, internationally technical assistant we have, we can change the coding system to the automatic system. Thank you.
Thank you, Iran. India?
Thank you, Chair. I fully agree with the distinguished delegate of Iran that we are struggling with various systems of automatic coding, and we are unable to decide which system would suit us better. And we would be well guided by the international community on standardizing some of these automatic coding systems that are in existence, because we do use verbal autopsy in India, but we do physician coding after the lay reporting of the death by the laypersons who are health workers. I would also like to expand the debate a little further that the health system is in touch at the antenatal, the natal and the postnatal stage, and the health workers play a very important role in informing both in the antenatal period about advocating the CRVS and the importance of CRVS, and in the postnatal period, especially when they are in contact with the mother and child through a mother and child tracking system or whatever you have in place, to ensure that the child is registered. So I think we need to place a lot of stress on the entire health delivery system, where not only the doctors, in India we've also tried to experiment by making the doctors at medical institutions the registrars. So a large number of doctors have now been also made registrars, and therefore the aim is that when the mother leaves the health institution, along with the immunization card or the health card, birth certificate is also issued. We are trying to, there is resistance to such efforts, but I think we are trying to overcome that resistance among the doctors. I was particularly interested in the maternal mortality audit. Our experience has been that once the spotlight is on the doctors, when a maternal death takes place, there's a tendency to discharge the mother before death. And when the mother is brought to the next institution, she is declared as brought dead. And therefore the mother, this maternal death falls through the cracks. So I think we need to insist upon the underlying causes to ensure that every death, even a brought dead to an institution, if we go into the underlying causes, then we can definitely classify it as a maternal death. So many deaths, just because there is an audit and because there is a spotlight and there is some action taken based on the audit, there is a tendency not to record maternal deaths as maternal deaths. I would be happy to hear whether that is the experience of other countries too. Thank you very much for this opportunity to intervene.
Thank you for those questions. I see Lau.
Thank you, Mr. Chair. On behalf of the Ministry of Health of Lao PDR, we have to support everybody and then agree with everybody here. In the Lao PDR, of course, that we have a certificate and notification of birth, and in the level of university hospital or central hospital, district hospital, except health center. That's a big problem for us because this certificate should delivered by the chief of the village. That's difficult. But for the hand, we have since 3 years one reform of the hand, like free delivery or free children under 5 years treatment to reach our MDG 4 and 5. But we have, for the cause of death, we have a big problem that you have mentioned already, Chair, that about autopsy. Of course, that the cause of death only from the symptoms. But autopsy, it's not allowed in our tradition because they don't like that we operate their parents, the children deaf, so like that. No, that's difficult, first of all. And then the second thing, in Laos, this is the problem from geography too. The remote area, mountain area, and minority ethnic, many dialects, many traditions. That's difficult. So, of course, that the funding is limited, and the personal skill and knowledge too limited. So like that, we have read your publication here. In November 4 and 5, you have training in Geneva for this statistic, but Laos is not invited. So that's sorry. But we have to disseminate this to our people after that, yeah? Sure. We've been proposed to WHO to make another training, especially for our country there. But I would like to tell you that we have to train the midwife and the OB/GYN doctor to make the statistic themselves, because we have a big lack of the number of statisticians in our country. And then we use this doctor and midwife, sometimes nurse, chief of nurse, to make statistics themselves. And the people from the Department of Statistics, they come to pick up or collect from this doctor from the hospital. We have done like that in our country. What's proposed is the next training from WHO. Thank you, Chair.
Thank you, Laos. I'd like to now come to the panel members to respond to any of the issues raised or any additional issues you want to bring up. Let me start with Pakistan.
It's kind of hard to disaggregate between questions and comments, but to the best of my capability, I think I can answer 2 questions. From Bhutan, it was the comment and question was raised that there is some advancement on the coverage of CRVS, but there are some issues about the quality of the data. So one possible solution is to install a small third-party audit, maybe a neutral body may be requested to do an audit to enhance the quality of the data. And then I will concur with one of the comments raised by Indian delegate, especially in the context of maternal death. If you look in the context of developing, if you compare the developed countries' health indicators and their capability to know the causes of maternal death, they are far advanced. So they have much lesser issues. But when it comes to developing countries, because of the gap of resources, because of the weak governance, and resources may be there, but still mothers are not able to go to the facilities. They may not be able to get the right diet and so forth. So the issues of the developing countries are much different than the developed countries. So the kind of efforts, kind of the gap analysis which needs to be done, and therefore the kind of the training which ICD may impart to the coders, I think the extent and depth of that training will differ in the context of developing and developed country. So that's my comment.
Thank you, Chair. Similarly here, not particularly on the questions, but generally I would also like to highlight on when we talk about modernizing the role of health. I think there are a few things that comes along with modernizing, that is finances. For example, the national planning actually should consider adequate financing in order to modernize systems already in place, and also there should be legislative frameworks or strong legal and regulatory mechanisms also in place so that even for modernizing to happen. And the third one is making use of opportunities to create awareness on registration. Similarly to the Indian delegate who mentioned about making use of antenatal clinics, the postnatal clinics, as well as the vaccination time, where mothers and parents can actually be made aware of the importance of registration, and also enforcing or improving the healthcare workers' role of understanding the importance of CRVS. So that's my point.
Thank you.
Okay, rather to comment on the specific question or the issue by the delegate, I would like to come up with the general comments that the concerned issues are also relevant to the challenges that the health sector in Cambodia try to address in the coming year. For example, with regard to the improved data qualities, coding, ICD codings, or communication, how to use the data, sharing the data between the health facility and the registration office. One particular concern about the maternal death, maternal death audit. The maternal death audit that currently conducted in Cambodia is basically the likelihood of verbal autopsies. And we use, in the maternal death guidelines, we have the different modules very related to the pattern of the cost of the children during the pregnancy, delivery, and the post-deliveries. There is the detail of the procedures which are indicated in the guideline to guide the physician or the maternal audit team to conduct this process. So I think we also have our professional, the physician, come along with delegation, and because of the time, I think if in the delegation we to get further information, then we can discuss later dates.
Thank you. I think there was one specific question aimed at me from Bhutan, which was how does the ABS's automatic coding system work? And I'm going to disappoint you. I cannot give you much detail about that. I'm not an expert in that. But I can tell you that Annika Schneider, who now works for the World Health Organization, used to be director of our vital statistics area, and I'm sure she'd be able to give you some information. But if she can't help you, then let me know and I'll put you in contact with the right person in Australia. I just thought I'd make another observation listening to some of the conversation, and it seems to me that we interchangeably use terms like notification, registration and certification. They're all distinct things. First you can notify, then you can register, and then you can certify. And if you think of your processes in regard to those three distinct things, then it might, I don't know, be a little bit easier to think of ways in which to improve your systems. And I know, for example, in some countries, a barrier is the cost in terms of issuing a certificate. And I think I heard one delegation say that the longer it goes, the more it costs, which is not much of an incentive. In Australia, it's free to register, and it's compulsory to register, but the certificate is what costs money. But if you think of the certification, the issuing of the certificate has been a different event from the registration, even though the two things are related to each other, and build systems around, you know, this notion of distinct events, then there might be ways in which you can knock down some of the other barriers that might be there in your countries in order to producing complete coverage of births and deaths. Thank you.
Thank you. Annika, can I invite you to add a few words?
Thanks, and it's very interesting watching a panel with my former boss and my current boss on it, and they throw the floor to me. Thank you, Batan, for your question, and I think we'd be very happy to talk to you about your observations about the number of characters that you should code to just at this point. With automated coding, it requires good medical certification and an electronic capture system so that you can put your medical certificate into the system easily and it will generate a code. You still require coders to be trained because there are certain events that can't be coded in the system, or it might throw things out at you. But I'd be happy to talk to you about how the Australian system works as I remember it.
Thank you, Anneke. Just because I think some of the questions were also directed towards WHO, and since I'm the only WHO member on the panel, I guess I should give it a try. So, indeed, cause of death, reliable cause of death information is a challenge, basically to every country, because it's not so easy. But it's good to distinguish between the two components, as many of you did in the questions. There's the hospital part of it, and then there's the community part of it. And typically in a country, the proportion that dies in hospital can be anywhere below, it's always below 50%. I think many people die at home. But in many countries it's below 20%. So we're talking about a relatively small proportion of deaths that occur in hospitals in many countries. There's the certification process, which is done by a physician, mostly based because the law says that the physician should do it. But obviously there is no reason why it can't be done by another health worker who is properly trained to do the certification. So meaning that the rules of certification as specified in the ICD are known and applied and work towards the underlying cause of death. Then there is how do you then code it, and there are coders, and someone has said, yeah, well, doctors are probably not such good coders, and that's true, or there's a real challenge because of turnovers to get them trained. So there are specific professions, coders, or the automated tools, and I think the challenge that you said, well, the language problem with IRIS and so on, is we're very much aware of that. The ICD-11 revision is going to be a much more digitized version, but this is a very long process, which is already 8 years underway. We have as a target date 2017, but we will still need to discuss whether that's feasible. But there, the idea of automated, easier coding is very much being pursued. There's also the shortlist that we have just completed recently, and I think some countries are actually already using a shortlist which has about just over 100 causes. And I think, as Dr. Kiri mentioned, many countries are using web-based reporting systems of on facility deaths and other kinds of information. We are incorporating that, for instance, in the DHIS version 2 that several countries are using. So it would be easier to at least use the shortlist and not the 3-4 digit codes. And then there's the community death part. And I think, as the registrar from India mentioned, verbal autopsy is a tool that we could use to determine a probable cause of death, because otherwise there's no information at all. And we know that hospital cause of death patterns can be very different from what happens in the community. So one needs this kind of information, and we recommend verbal autopsy. Now, there is, since a few months ago, there is a standardized verbal autopsy questionnaire. There was a 2007 WHO version. This is the 2014 version, which is remarkably shorter. We call the 2007 one now more a research instrument. This is a shorter instrument which can help you define, lead to, or diagnose a number of causes of death, a couple of dozen, so leading causes of death. Now, this standard instrument is there, but then how do you get to the code or the cause of death? And we've mapped those causes onto the ICD so that in the end it can be put together. So there are different ways. One is using physicians, as has been done in India on a very large scale, or there are different pieces of software that do that, such as InterVA and Tariff and others. Now, we've been working with all relevant players over the past year to try to get this common instrument, which we got, and then different pieces of software can be applied to it to generate a probable cause of death. At the moment, I don't think it's completely clear which one is the best. I think they all have issues, and it's only a probable cause of death that we get out of these interviews. But I think it's so automated has one big advantage over physician. It's cheaper and faster. So I think that is an important consideration, particularly if numbers are large. So to conclude, I think, and I just wanted to draw attention to one other publication that's out there, because it just is hot off the press, and it's outside of this room. It's about improving mortality statistics through civil registration and vital statistics systems. And it's a preliminary guidance for country strategies and partner support. When we strengthen civil registration and vital statistics systems, there is the expectation that this will help mortality statistics. It will indeed, but only if specific investments are made to do so. Otherwise, it will take a very long time. This guidance sort of looks at different systems where they start below 60%, 60 to 80%, over 80%, and what kind of actions would be needed to get more reliable statistics. So to conclude, I think we've heard a whole range of innovations in the health sector that could really contribute towards strengthening CRVS, which is great. We also heard from, I think, Malaysia, the need for health sector, the responsible authority for registration, statistical officers, and probably others to work together and in a very strong coordinating mechanism under high-level government leadership to come to a system that really produces the vital statistics, the high levels of coverage of birth and death registration. So I think that's, in the health sector, I think we're really committed. Now globally, we're trying to find out how one can support countries best in this process. But by all means, this is not like a household survey. Government leadership and commitment will drive this agenda, or it won't happen. So thank you very much. And thank you to my fellow panel members for a very interesting session.
Excellencies, distinguished delegates, ladies and gentlemen, thank you to the panel and delegates for such an informative and engaging discussion. There will now be a short transition as we prepare for the second of today's special sessions, Pacific Vital Statistics Action Plan, Experiences and Lessons for the Asian Pacific Region. This has been organised by the Brisbane Accord Group.